Hi everyone. So I am a methodologist. This is my first chance to dip my toe into drug repurposing. But I'll just explain to you about the core outcome set development process and about how we incorporate patient perspectives into the selection of the outcomes and the measurement of them. Okay, so as you know, when we design a clinical trial, we want to know whether or not an intervention or new treatment has been effective. And to do this, we measure outcomes. So outcomes or endpoints, you may refer to them as. So the selection of outcomes is a crucial aspect of trial design. It's essentially what the intervention is trying to improve or avoid. So some examples would be survival, quality of life, adverse events, and so on. But there's quite a lot of problems with outcomes. So there's inconsistencies in the outcomes that are included in clinical trials for a given condition. There's also variability in the way the key outcomes are measured and then reported. We have selective reporting bias, so where only those outcomes that are significant are reported in the final paper. And these issues lead to difficulties for decision makers because you're unable to compare and combine the results from the different studies. They can often lack input from patients and others who make decisions about healthcare. And so they're not in the best interest of anyone in the decision chain. So one solution is the idea of a core outcome set. It's an agreed, standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. So the important aspect is that the core outcome set is the minimum outcomes. We're not saying that trials should only measure these outcomes, but there should be a small core group that would be measured in all trials for a specific disease area. And then trialists would be free to add additional outcomes that are relevant to their specific trial. So the core outcome set doesn't have to be the primary endpoint. It can be the secondary. It's just as long as we capture them, then we can compare as we know, participating in a clinical trial has a huge burden for everyone involved. They cost a lot of money. It's a lot for the trial team. And then, as we've heard, for patients to take part, it requires a big contribution. So we want to make sure that what we get from trials is usable. So what are the advantages of a core outcome set? Well, they increase consistency across trials. They maximise the potential for trials to contribute to systematic reviews of key outcomes because we can compare and contrast. They are much more likely to measure appropriate outcomes, and that's because, like drug repurposing is a team sport, so is the development of core outcome sets, because you've got these key stakeholders that should be involved in the development of all, and I'll go into that a bit later. And they can also lead to major reduction in selective reporting, because if you're measuring these core outcomes, you're then reporting on them. So I work with a group called the Comet Initiative, and we launched at a meeting in Liverpool in the UK in 2010. And we wanted to raise awareness of the problems with outcomes in clinical trials. And then we wanted to encourage core outcome set development and the subsequent uptake of these core outcome sets. We wanted to promote patient and public participation and involvement in core outcome set development, and then provide the developers resources to facilitate them to do this. We want to avoid unnecessary duplication of effort. So this is a big area for us at the moment. So the idea of core outcome sets is to reduce waste in research. And that means we don't want people developing multiple core outcome sets in the same area. So we do a lot of work trying to avoid that from happening and to encourage groups to work together and collaborate. And we want to encourage evidence-based core outcome set development. So we have our website, the Comet website, and it contains a publicly available repository of all core outcome set development studies. We undertake an annual systematic review. We have regular database alerts, so studies are continually added. And then we also have prospective registration of new core outcome set development studies. So Comet as a group do not develop core outcome sets. We support those to develop them, but as individuals within our management group, we are involved in the development. And core outcome sets have been developed across a range of different disease categories. The most prevalent areas are cancer, neurology, rheumatology, heart and circulation, but there's lots of others. And we do some work to identify gaps of how they map onto the global burden of disease to see where core outcome sets are needed. Core outcome sets and COMET are endorsed by various groups. So we have trial registries, funders, regulatory groups, and just last year the WHO released their guidance for best practice in clinical trials, where they endorsed the use of core outcome sets. And we actually worked with the World Health Organization when we developed our core outcome set for long COVID. So we do a lot of work trying to work with these groups to just increase the awareness of core outcome sets. So I'll just tell you a little bit about the process of developing them. So you would start off by identifying what outcomes have been reported in the literature for a given health condition. And then you would usually, what has been measured neglects that patient perspective. So we'd advise developers to do some work with patients. It may be qualitative work or use of existing literature on patient perspectives. And then the developers will consolidate all these outcomes they've identified into a long list of outcomes, and they classify them into domains and basically reduce them down into a more manageable list that would go forward to the consensus process, where you would ask your participants to rate the importance of outcomes. So Ranga mentioned previously about a Delphi process. So this is a common method used to develop a core outcome set, where participants would rate the importance of outcomes and then ask to re-rate them, being made of how other stakeholders have scored each outcomes. And then you may hold a final consensus meeting to reach agreements on the core outcome set. So we provide resources to support core outcome set developers. We have standards on the development, a checklist of items for protocols, reporting guidelines. We have a COMET handbook, and then we also have guidance for the measurement stage, which I'll go into shortly. But in terms of the core outcome set standards for development, or COSSTAD, this focuses on the scope specification, the stakeholders who are included in the process, and the consensus process. So basically, we advise developers to clearly specify the scope, so the setting, the population, the health condition intervention for which the core outcome set applies, so that people actually know if they want to use it, who it's relevant to. The stakeholders, which I'll go on to in the next slide, and then also the consensus process. So in terms of stakeholder input, there are 3 key groups that should be included in the development of all core outcome sets. They are healthcare professionals who have experience of treating the condition, patients or their representatives who have experience of living with the condition, and those who will do the research that will use the core outcome set, so clinical trialists, pharmaceutical industry, and they should be involved in the development of all core outcome sets. I mentioned the Delphi process, so you wouldn't have to have equal numbers in each group because you'd reach consensus in all groups separately. For an outcome to be included in a core outcome set, all of the groups must consider it essential to include. And by having something like a Delphi, you can see health professionals can see how patients have scored an item and so on. So in terms of patient participation, involvement, engagement, I know the terms are quite interchangeable, often depending where you are in the world. In terms of core outcome sets, we define participation as participants who are contributing to the research. So whether they're taking part in the qualitative aspect, or they are rating the outcomes in a Delphi survey and contributing data to the study. Involvement refers to when the patients or their representatives are research partners, so they're involved in the design and the running of the study. And then we have engagement, and I know the terms that, but we consider engagement as sharing the results of the study later on. So in terms of patient and public involvement in studies, we have, well, within COMET, we have a POPI working group. So they're an amazing group of team who advise on the participation and public involvement in COS development studies. And they've developed the patient and public involvement toolkit. And it's basically guides COS developers on how they can do PPI in their COS development studies. And that's available on the COMET website. And then we have other resources. So we've got videos, multimedia resources explaining core outcome sets in plain language terms. We have resources that are designed like targeted at patients to explain the process, and then resources for researchers who want to involve patients or include them in the process. And as I said, we've got the Poppy Working Group who do a lot of this, but all this can be found on our COMET website. So if we look at what has happened with patient and public participation over time, we can see that when we done the first review of core outcome set, it was just 15% of studies that had included patients within the process. And we followed up with a couple of these groups to ask why they hadn't included patients. And clinicians would say, well, we already knew what the patients were thinking, so we knew what outcomes were important to them. Thankfully, we've moved on. And in the latest review, 90% of studies included patients, and from the ongoing, it's almost all of them. So what impact do patients have? Well, we've got clear examples of where including patients in the process has led to additional outcomes being included in a core outcome set. One of the big examples is for rheumatoid arthritis, which is one of the successful core outcome sets. And the patient input led to fatigue being added. And there's examples for other conditions as well. And when we look at the outcomes, if we compare the core outcome sets that have not included patients versus those that have included, we see that the functioning type outcomes, so activities of daily living, emotional well-being, role functioning, are much more likely to be included in core outcome sets when patients are included. So their input is vital to that final set. So I'll quickly just go on to the next stage. So once you've done the what to measure, the core outcome sets, the next stage is identifying how to measure them. And we work with a group called Cosmin, who are based here in Amsterdam. And we developed a practical guideline for the selection of outcome measurement instruments. It's a best practice guideline saying how you should go about selecting the outcome measurement instruments. And it's a 4-stage process that's explained. So you'd find existing instruments, you'd assess the quality of them, and then make recommendations. But the issue is people often think that this is a process that patients shouldn't be involved in. It's now accepted that patients are included in identifying what to measure, but they just think the how to measure is just a stage too far because it's, assessing the psychometric properties. But I would argue, well, this isn't what clinicians do on a day-to-day basis, so why is it okay to include them but not patients? And there's definitely aspects that patients can be involved in. So if you look at the feasibility and, the face validity, these are key aspects that patients can be involved in. They're the ones who will go on to complete the measures, so they need to be acceptable to them. So in our core outcome set for long COVID, we developed instrument cards that contain key feasibility information about each of the measures. And we had a plain language summary we developed in collaboration with our patient research partners just to highlight these key details. And so it definitely can be done, and we included quite a lot of patients. More work is needed, and it's something I'm interested in to look at the best methods to include patients and other stakeholders in this process. But just to sum up, if you are interested in core outcome set development, you can register to receive alerts of newly published and registered studies via the COMET website. But thank you for listening.